Hi, I'm Ken Cutbush. I'm an orthopaedic shoulder surgeon working in Brisbane. I'd like to share a case of a patient of mine with you. He's a 19-year-old man who's come to see me. He first dislocated his shoulder when he was 17 playing AFL. He had significant injury, dislocated his shoulder, and we'll look at his MRI scan then. So this is the MRI scan when he first dislocated his shoulder a couple of years ago. This is the rotator cuff at the back. This is the back of the shoulder, rotator cuff at the front. Biceps is here. You see the deltoid muscle and then skin. This bright area in the back of the humeral head is bone bruising. It's fluid content in the back of the humeral head related to the recent dislocation. And he's got a dent here in the back of the shoulder, an indentation there. That's from the shoulder coming out, dislocating out here, and then coming back and hitting this corner of bone here, the corner of the socket which dents here, and then you get bone bruising related to that. He's also torn the labrum at the front of the shoulder. You can see labrum at the back of the shoulder. This triangle here is fiber cartilage. The black line across here is bone, and on top of that you've got 2 layers of cartilage. At the front he should have exactly this mirrored to the front of the shoulder. He should have a labrum at the front of the shoulder that you can clearly see, but it's torn down through here, and this is labrum out here. So he's got a labral tear at the front of the shoulder, and at the back he's got a Hill-Sachs lesion, which is the indentation there. So typical appearance of an MRI scan of an acute dislocation. He's then had shoulder surgery with a very good shoulder surgeon. He had a labral repair, and that went well for a couple of years, and unfortunately he's re-dislocated again, playing football again, and popped the shoulder out with another significant injury. And this is the MRI scan now that he's come to see me with. You can see labrum at the back of the shoulder is still intact, but at the front of the shoulder he's got an anchor point here, and unfortunately he's re-torn that repair. The labrum's out through here, and there's a tear line down through here. I'll show you his CT scan. So this is a 3D reconstruction. You can see at the back of the shoulder, we've got an indentation here. That's the Hill-Sachs lesion here. You see it more easily maybe as I spin it around. You see there, this is where the indentation is. That is from the shoulder coming out the front and then hitting back against this corner here. You can see where the previous anchors have been placed for the previous labral repair. So this is the normal right shoulder. You can see it's got quite a pear shape to it, much wider at the bottom than at the top, and that's what we'd like to see. We'd like to see a pear shape to the socket. On this side, however, if we bring it around so we can have a look at it, and we compare the two together, you can see an obvious pear shape on the normal right shoulder, the uninjured right shoulder. On the left shoulder, it's no longer pear-shaped. He's chipped off a piece of bone at the front of the shoulder here. You can see anchor points from the 3 anchors being placed previously. Now what I've done for him is a Latarjet procedure. And what that is the bone from the front of the shoulder, this coracoid process here. Here we cut this off at the base, and that's transferred down to the front of the shoulder and then fixed with 2 screws. And you can see that here. This is the 6-week post-op x-ray or post-op CT scan. The bone block is nice and low on the front of the socket. You can see that the outer margin, the lateral margin or the outside edge of the bone block is level with the surface of the glenoid. That means it's stepped back a little bit because you have a layer of cartilage there, and that's exactly where we want to see it. We don't want to see it any further what we call lateral or this way outside of that, because that will predispose towards early arthritis. And at the same time, the most stable position is at that level there. If we put the bone block further this way or inwards or medial, then it becomes less effective in terms of stabilizing the shoulder. You can see the 2 screws there. The bottom screw is just skating along but is capturing the bone there. So that's as low as we go. We can't go any lower than that. And you see anchor points from the 2 anchor points to repair the labrum. I've repaired the labrum over the top of that bone block. And if then we go to the axial slices, we see that at 6 weeks post-op, that bone block has united to the anterior glenoid there. We can't see the 2 bones as being separate. So we're very happy with that, and at that point we're able to accelerate his rehab program and get him going with the physios without any restrictions from me. So that's just a nice case of a patient who'd had a successful stabilisation, had it fail with another significant injury, and then we fixed it again with the arthroscopic Latarjet. Thank you. I just thought that was a nice case to share with you.